Hi, Marie.
Hello.
Hi, everybody. Well, hey, thanks for joining us this evening. It's definitely a pleasure to see everybody. And we're recording this so that others who couldn't make it tonight could actually see the video. We're here on the I guess the District Health Service Committee, and it's part of a series of talks for this fall, spring, sorry, that we're giving. And Dr. Paul Morose today will be giving a talk on in-flight emergencies. And this is something that I think everyone in Hawaii probably has flown at some point. And there's always that concern that something might happen, and whether to yourself or your family members or to someone else. And what better than Rotarians to kind of have some tips and kind of understand kind of how the process goes, just in case we're called to action, regardless if you're a healthcare provider or not. Yeah, Paul is a member of the Rotary Club of Honolulu Sunset, my alma mater, and we're just fortunate to have him here. He is one of a few, actually, the only one I know of that's a pediatric orthopedic spine surgeon, and he's at Shriners, and he's been a tremendous help, not only through Rotary, but also just through other parts of our community here. And at the end of all this, he'll also probably give a talk about some exciting developments that are happening for ways for us to help, halfway around the world. So, which will obviously have to fly to get there. So it kind of makes sense, kind of relate to this talk. So, but without further ado, I just want to give a big warm welcome to Paul Morose. Thank you, Paul.
Thanks a lot. So yeah, all the reasons for, we all travel and you never know what's going to happen. And, in my career, I've been, called up to go, and it's always a bit scary. And so what are the implications and that sort of thing? And I'm sure there's lots of people here with experience. I am an orthopedic surgeon. I'm not an emergentologist like James, so he's probably more ready to jump on stuff. And I've got some funny story. I was going to tell a story, like when they call for a doctor, I have a 20-second rule. I wait for 20 seconds before, because there's probably someone else there who's probably more qualified than me, and usually that happens, but I'm always ready to help, and with hands or putting in an IV or something like that. So, but anyway, and I've been on planes where an entire plane is full of doctors coming back from a convention, and they ask for a doctor and nobody puts their hand up, usually because everybody's had a few too many drinks. And so who wants to get involved when you've got alcohol on board? So James, I'm giving away all these trade secrets. You got to stop me. So anyway, okay, so you know what? Here's some statistics. I'm not going to go through all of these, other than to tell you that flying is extremely safe. It's much, much more dangerous driving a car. Driving home tonight from work is going to be infinitely more dangerous for me than either on my bicycle or on my bike than flying on a commercial airline. The only thing to do is be careful which continent you're on. Africa has about 4% of continental air flights, but has about 27% of accidents that happen on a yearly basis. So flying in Africa is, you got to be careful who to fly with. So, New England Journal of Medicine, there was a good paper on this a few years ago, and still it seems to be the one everyone refers to. And so they looked at a whole pile of emergency calls to medical communications over a period of months, and basically one emergency per 604 flights. And diversions, what does that mean? That means when the aircraft actually gets landed or moved to land because of the emergency, happens in about between 5 to 10% of calls. And so, and that costs a lot of money. It costs from, 50,000 to one statistic was $853,000, almost $1 million to divert a plane. So it costs a lot, and that sort of thing. So airlines really don't want to do it. And that's part of the reason almost every airline now has a call into an emergency center 24/7. There's two places. I think one's in Denver and one's someplace else on the East Coast. Maybe James knows, but they're always ready to take a call from any plane and pretty well anywhere. And so, and of these, in this particular study, 25% went to hospital, 8.6 were admitted, and a very small percentage died. So what are the major causes from this study? These are the big causes. So I apologize for the largely medical talk, but you're all educated. What's syncope or pre-syncope? Fainting or pre-fainting? Like, oh, I feel faint, I feel dizzy. That's pre-syncope, or syncope is actually fainting to the point where you're unconscious. Is the big bulk of a lot of calls. And then you see the list down there from top to bottom: respiratory symptoms like an asthma thing or something like that, nausea and vomiting, cardiac symptoms. Now, a lot of these statistics are pre-COVID too, but I don't think much has changed right now. COVID is more the infectivity issue with not the actual problem on traveling. Unless you count fights over masks, that's a big factor now. And I'm not going to really get into that, but we all know that the assaults and the problems with angry behavior has skyrocketed 3,000% in the last couple of years since COVID came. So I'm not going to touch on that too much because that's more behavior and maybe we'll get some of your thoughts on that because there's not really a lot in the literature. Nausea and vomiting, cardiac symptoms, probably cardiac symptoms and seizures, the biggest problems, and then we'll get a little bit more. So, in this particular study, of the 36 deaths that occurred, most of them were cardiac, and so most of those people they get on board with a cardiac history. So if you're getting on board with a cardiac history, you need to be prepared. You need to have your stuff. Someone needs to know what's wrong with you if that's possible. And you got to be careful if you've recently had a procedure related to your cardiac thing that you're not going too soon. And so death's pretty rare. So what are the factors that you're dealing with when you're getting on a flight? Well, you're at a 35,000 feet, but it's at about an 8,000 foot equivalent environment. And we'll talk about that in a bit. Who walks on the plane? So that's your pre-existing medical conditions and the recommendations that you should get from your doc. And then the common medical problems on planes we'll talk about. And what are the resources on a plane? We'll talk about that because they may not be as extensive as you think. What's the aircraft environment? Well, that's the conditions on the cabin that may stress you out. And most of them have to do with barometric or pressure changes at high altitudes. And then on top of that, there's the air quality. It's dry, it's low humidity conditions that can also cause problems. So why don't they make special efforts to make the humidity normal and all that sort of stuff? Well, we'll talk a little bit about that. But when they keep telling you to stay hydrated, they're doing that for a very good reason. And then drinking alcohol can contribute to dehydration. So here's a scenario, but I'll give you a talk about. So July 2008, July 25. It's Qantas Flight 30. A loud explosion and a sudden rushing in of air into the cabin. And there's a sudden decompression at 29,000 feet, which is about the height of Mount Everest. And so there were 369 souls on this flight. It was a 747, and the crew rapidly depressurized following a forceful rupture of one of the aircraft's emergency oxygen cylinders in the cargo hold. And it was just outside of a flight between Hong Kong and Melbourne, Australia. So what would you do? Sudden decompression at 29,000 feet. The question is, how much time do you have before you pass out? And what should occupy your time right now? So that's what the question is. So I'll just answer the question. So at 29,000 feet, you have about 3 minutes before you pass out at that altitude. And so if you're a smoker, you have even less time. So when they talk about all those oxygen things that deploy from the top of that, and they say, get it on now, that's what you just should be spending your 1 or 2 minutes, is getting that oxygen. And remember how they always say, remember to put it on first. Don't put it on somebody else. Don't put it on little Johnny, because you're going to pass out while you're trying to do that. And then you're both going to die. So put your mask on first and start breathing. You can't help others if you're unconscious. And there's a question. There's a question from the peanut gallery. Yes, sir.
No. I just wanted to add that now they're saying they have to remind us to take off our face masks before we put on the oxygen masks. I thought that was kind of silly. Every airplane now they have to tell us that. Just it's a reminder, I guess.
Yeah.
Oh, Paul, I have a question about the pilots. How soon will they become unconscious, or do they have a special in there where they're sitting in the airplane? Is that special where it's there? compression or the
Well, in an
decompression is-
emergency like a sudden decompression like this, they're kind of in the same boat as us, but what they get deploying out of them is much better than what you're getting. So they're going to get and I'll go a little bit into more of what you're actually getting in your oxygen supply, but what they get are sort of like semi-space oxygenated full facial mask stuff. So anyway, so when you get cabin depressurization like that, then so what's the plan for these planes when this kind of boom happens? So they want to descend rapidly to 10,000 feet because most people can live at an altitude of 10,000 feet. So they're going to descend really, really quickly. And that 3 minutes is what they're counting on for that oxygen to get you down to that 10,000 feet. Because the loss of cabin pressure and equalization of the pressure of the planes, so it can be slow, rapid, or explosive, but if it happens at cruising altitudes, you got to get down. And so they talk about this time of useful consciousness. And so this is a summary of the time of useful consciousness. So if you're at 15,000 feet, you've got a long time, you got more than 30 minutes to be usefully conscious, to get your stuff, so because 15,000 feet is, one of the mountains in the Cascades in Washington State or something like that. But at 50,000 feet, you've got very little time of useful consciousness before you pass out. So aircraft operating between 30 to 39,000 feet, an aircraft cabin pressure is about the equivalent of 7,000 or 8,000 feet. And so here you see the barometric pressure decreases exponentially with altitude. Okay, so, and then at normal altitude, normal oxygen that we're breathing is about 21% oxygen. Okay, but at 8,000 feet, it's less. So if you're already compromised because you have, you're anemic, you don't have enough red blood cells in your body because you might have a mild myelodysplasia or your cardiac system's not working up to snuff, then that can be compromising. And so that's why you need to get that oxygen on. This is just a schema showing that at 36,000 feet, the PSI pressure is about 3.3, but the cabin pressure is 11.3 pounds per square inch is the pressure inside the in the plane. So if you suddenly lose pressure, do you remember Goldfinger, the movie Goldfinger? What happens to Auric Goldfinger when Bond shoots the window out? Because he's well strapped in his seat, but Goldfinger isn't because he's too fat. So he gets sucked out of the plane, and there goes Auric Goldfinger. So that's what happens when you get sudden decompression because of pressure. So normal aircraft cabin altitude is about the range of about 7,000 feet. They're trying to pressurize it a little bit better. Some planes are 6,000 feet, but maximum altitude is about the equivalent to 8,000 feet. Why not pressurize the cabin to sea level pressures then to make it safe for everybody? Well, it has to do with the aircraft design right now. So, they're all made out of aluminum, right? And so their stress cycles to metal fatigue are high if they pressurize them. And so now the more Dreamliners now have carbon fiber fuselage. And so they're resistant to fatigue, cycling fatigue. And so they can take cabin up altitudes of about 6,000 feet. So some of you longtime Hawaiianer may remember the 1988 Aloha Flight 243, where it was an inter-island flight, and this fuselage off the roof got ripped off. And one veteran flight attendant of 37 years, CB Lansing, unfortunately was flown away and sucked out and never to be found and perished. And but no one else died, and everybody else. And look at that fuselage. Look how much that fuselage was exposed, and the seating and all that. But and they thought the metal fatigue exacerbated by crevice corrosion and multiple, pressurizations and dispressurizations was thought to be the cause of this in a 19-year-old Boeing 737. So, but look at that hole. You'd think a lot more people would have died in that, but only one did because she was serving stuff, right? She wasn't strapped in. So it shows that the system can work. So this is the oxygen bag you get. It doesn't look like much, but it seems to work, and it'll get you through. So there it goes down, and you got to put yours on first and then give it to Johnny. And then but there's only about 12 or 15 minutes of oxygen once you've pulled the cord on it. It has a little lanyard that pulls a pin, and it's actually not an oxygen tank. It's a chemical reaction in planes right now. And they burn chemicals, which releases oxygen as a byproduct of the chemical process. And that's why you can smell kind of a burning thing, and it smells kind of chemically. And you've only got about 12 or 15. That's enough time for them to get down to 10,000 feet. And so they can't give you enough oxygen for every passenger to have a supply until you land. They just want to get you down to a safe altitude, 10,000 feet or even lower. Now, the pilots, you'll bet they got real oxygen in there, and they'll have that for several hours, I would imagine, depending on the nature of their flight. If it's an inter-island flight, probably less, but if it's a transatlantic Pacific flight, probably more. So you tug the mask, like you see in the demonstration, and it starts a chemical reaction that won't stop. And it's got about 12 to 15 minutes. And then don't expect that bag to inflate, just breathe in it, and sometimes it'll partially inflate if you inhale less. And so the oxygen generator above you can get pretty hot as well. So that's a little bit about the oxygen. Now, Boyle's law, everybody remembers in physics. So one of the things that can happen in the ear, in the guts. So basically Boyle's law is that if the pressure increases, then the volume decreases. Put another way, if you've got a gas bubble in your gut and you go to an environment that has less pressure, then that gas bubble in your gut is going to expand, and it's going to give you a tummy ache. And I remember a flight from Delhi to London on my first trip to Nepal. They were asking for a doctor, and I was just a medical student. I wasn't even a doctor. And so Claire, who wasn't even a medical student, volunteers me on this big, big plane. And long story short, it was just a little baby with gastritis or something like that, probably from a pressure thing like this. So, and then the purser asked me, "Oh, do you want to land? The captain wants to know, do you want to land the plane?" I go, "Oh, wow. Where are we?" "Oh, we're over Germany." I go, "Nah, I want to go to Delhi." So I think this kid will survive, and he did. And so, but it was probably, so a lot of things come with gas. So what's ileus? Ileus is the doctor term for kind of your stomach gets a little bit stunned from gas expansion and may not work very well and gives you a tummy ache. A pneumothorax is where you can expand something in your lungs and it can actually collapse your lung. Anything that has, like in otitis media, is an inner ear thing, or a sinus in your nose that can expand. Pneumatic casts, so if you've got a cast on, they can expand. If you've been recently scuba diving, you've got nitrogen on board. That's why they don't want you to fly for 18 to 24 hours after you've been diving. Or if you've had intracranial surgery, brain surgery, you could have a little bit of residual air in there, or a collection of CSF, cerebrospinal fluid, that may expand. So you need to get your brain surgeon to clear you before you can fly. Or a heart surgery, you usually want to wait for about a month to 6 weeks for all that kind of pressurized stuff to normalize before you get on board. You can't fool around with this kind of stuff. So that's a pressure thing. What about humidity? They talk a lot about low humidity on aircraft. Well, normal humidity, what's humidity? Is the amount of water vapor in the air, usually expressed as grams per cubic meter. And normal is about 40%. But on an aircraft, it's about half that, 6 to 8 or less, 6 to 18%. So why low humidity? Because they can't carry all that water to humidify the plane. And then, fuselage temperatures get cold at high altitudes, and you get condensation if you have a lot of vapor in the air. So that's a problem. They want to keep the humidity low, and that's why they keep telling you to drink. So, and only, so a lot of the air that comes through the plane, only 50% of it's recirculated. And so half of it comes from outside the plane. And at that altitude, it's really, really low humidity. So you just got to plan for low humidity. And if you're hyperventilating too, then you can get really dehydrated. And that's what leads to a lot of problems. So when they say hydrate, you should really, that's why they walk around giving you juice or even on these inner things, just keep hydrating. They don't do that because they're being nice. They want to keep you from getting an event. Most of the humidity in the cabin is provided by passengers too. As you exhale, you've got humidified air, but fresh air exchange reduces humidity though. And one of the reasons why COVID is actually pretty safe on planes, unless you're sitting to someone who's spewing viral load, it's actually one of the safest places to be, actually even safer than an operating room because of the air exchange inside. The flights are actually so efficient. So outside air has very low humidity. Dreamliners, they're getting better. And so drink water is the safest thing to do. So your environment on board has reduced oxygen pressure, low humidity, and the stress of getting on board and flying. So those are all stresses you need to be aware of. And then on top of that are your pre-existing medical conditions. So what about coronavirus? So air circulates from in a plane from the ceiling to the floor and is filtered on the airplanes. And so most viruses and germs don't spread easily on airplanes. And so they actually number of air changes per hour is pretty high, about 13 to 15. So that's better than an operating room, which is about 6 or 7 air exchanges per hour. And then the high efficiency particulate air filters and high turnover of airflow, the contamination is very, very low. So that's actually good for coronavirus. So very few places indoors are anywhere close to what a plane has for coronavirus. And the one really good study that I'm aware of, that what's the biggest risk on a plane is if the guy next to you actually has corona and is early on and his antigen is spewing antigen. So in the first few days of being symptomatic. So you're not symptomatic until 3 days after getting infected, then you're symptomatic for about 5 days after that. And that's when your viral load is high. And if you're coughing and snorting on a plane and you're right next to the person, that's a risk factor. Other than that, it's pretty safe to be on a plane, unless of course you're not following the rules and you're taking your mask off and stuff like that. So would you agree with that, James? Your awareness?
Yes.
Oh, okay. So so it's safe, pre-existing conditions. So coronary artery disease, pulmonary disease, diabetes, seizures, anemia, sickle cell disease, recent surgery are all risk factors that can give you trouble with these things. This is the same list we showed before. If you have cardiovascular disease, basically the bottom line is, I'm not going to go through all this, but if you've got angina, there's certain restrictions. You need to get checked out by your doctor. If you've had an uncomplicated elective coronary artery bypass graft, you can fly after 10 days, mostly because you've had a chest tube and you need that air to be reabsorbed in your chest so that it doesn't expand when you go to altitude. So if you have a history of heart failure, if it's been acute heart failure, you really need to be stabilized. And there are a bunch of criteria that James knows more than I do that you need to do before you fly. This is the bottom line. Decompression illness from diving, we talked a little bit about that. So, when you're diving at depth, you increase your nitrogen load and to your joints, and even in other places, lungs and brains. And so that comes out of solution as you come up. And so if you pressure changes, then it can increase your chance of developing decompression illness. So minimum surface time of 12 hours after a single dive, but most dives then are 18 hours to 24 hours to be safe before you get on board to fly home. And then you get deep boring pain, that's sort of the bends, what they call it. You can get neurologic things, even spinal cord lesions that can lead to paraplegia. And then the chokes can happen from bubble expanding in your lungs and that sort of thing. Bigger problem is probably deep vein thrombosis, especially a long flight. So DVT is basically a blood clot in your legs, in your calves and thighs. And so that's a real problem. It's not unique to air travel. Your sitting time increases a lot. And so even healthy individuals, if you sit for longer than 4 hours. So you really should learn to love anti-decompression stockings, because aspirin, is not people will say take a baby aspirin, that kind of thing. I think baby aspirins are kind of out now, but high-risk patients should consider low molecular weight heparin, but that's only through a doctor. Mobility, I used to get up all the time in a flight and walk around. I'd make sure I did that every hour, but now because of COVID, they don't want you doing that. And so I don't know if the DVT rates have increased, but I would predict but I haven't seen any papers to that effect, but those papers kind of come out 2 or 3 years after something starts. And so that'll probably be published next year, that sort of thing. So, but anti-embolism stockings, compression stockings you can get anywhere. And probably all of us should have those, and I use them as well. Diabetics.
Paul?
Yeah.
Yeah, this is John. I guess along those lines, the DVTs and all that, I have a syndrome that's antiphospholipid syndrome, which it means
Yeah.
I'm prone to clots,
Yep.
throwing clots in my body. And so is that, I guess that's the same issue with the DVTs. I appreciate your thing about the stockings, and I already take Lovenox and baby aspirin all anyway. So I guess that's part of that, the last one that you had there. So
Yeah, I would definitely get into. I wear stockings, and I don't have a history of DVTs, but I know after a long 6-hour flight, my legs are pretty puffy. I don't get pitting edema
right.
yet, but and I mean, they don't bother me, and so I'm using. I'm 63 now. I just turned 63 last week, and so I don't want to, because once you've had one blood clot, then that increases your risk of getting more DVTs after that, because you've done damage to the veins. Now they're more prone. So you don't want to get that first clot. So I'm trying to be preventative. So definitely, so.
Thank you, young guy. So
Thank you, sir. So if you're diabetic, you really got to have your stuff on board, and carry your glucose test strips, your insulin and syringes, because if you don't have that, then you can get into real trouble. I think most airlines try to carry a little bit of that on board, but yeah. So diabetes is complicated. So you just have to, ear, nose, and throat issues. If you have ear, nose, and throat problems, it could be dizzying. Most babies, get upset. And for a while, in my 20s, I remember I was always cursed with having a baby next to me. And what was worse was either the kid developing ear problems, or a mom, when I tell her, look, give your baby a bottle so that she swallows, because if the baby swallows, the eustachian tubes open up and it clears their ears. And then they go, oh, how do you know that? Oh, I'm a doctor. And then now they're talking for 4 hours about all their medical problems. So I don't know what's worse, a screaming baby or a mom who's talking. Anyway, so anyway, ear problems can be a real issue, tympanic membrane ruptures even. So contraindications to traveling. So when should you not travel? If you have a raging middle ear infection, effusions or fluid behind the ear, and then if you've had recent procedures, any kind of procedure to a sinus in your head or near your ears, or anything in your brain, you really got to talk to your surgeon, your ear, nose, and throat doc, or brain surgeon if it was brain surgery, to clear you before you go. So what about fractures? If you've got a cast on, and and then I just put a kid on a plane yesterday to Calgary with a broken arm, and so that changes what you do, because you can't put a cast on because the swelling in the arm can change at altitude. And so we put the kid in an adjustable splint, but then this kid will probably remove it, and then he'll lose his fracture reduction after I straightened it. It could bend, and then he's got to have another reduction when he gets to Calgary. So, but the risk of circulatory compromise or nerve compression if something becomes too tight at altitude, because again, things change with pressure. So, air should be released to allow for gas expansion if you have a pneumatic kind of brace, but a lot of people don't have pneumatic braces. British Airways has a policy on plaster casts. If you have a broken bone and a plaster cast fitted, you can't fly within 24 hours. If your planned flight is less than 2 hours, or 48 if it's longer than 2 hours. So check with your airline when you got braces, but we usually either split the cast that allows for expansion, or we put them in some kind of an adjustable brace and then just warn them, because it's unlikely if you've got a full circumferential fiberglass cast and you're at 35,000 feet and you're having problems, they probably don't have a cast cutter or a cast saw to cut through fiberglass. And so that could become a real problem. So what about neurologic problems like seizures and syncope? It means that fainting. And so these are all kinds of problems that you can get, and they're very common. and they're second only to cardiac events in requiring a diversion, because neurologic incidents are scary when people lose consciousness, when they start to have seizures, when they start to have stroke-like symptoms, like one side face drooping or drooling or inability to speak, or visual disturbances. So they can be very scary to everybody, and that can cause divergence. So and then seizure threshold decreases when you're deprived, when you're sleeping, or you're dehydrated, or you've got a lot of alcohol on board. And so it's the second most common in-flight neurologic incidents are seizures. So TIA and stroke, in-flight, I don't know about the thrombolytic therapy for strokes in flight precludes it, but maybe it's because the time to get down to get thrombolytic therapy, which is a clot buster. By the time you get down, you've got like 3 hours to get to the clot buster stuff. And so you might not be able to do that if you're at altitude. So, and then you got to avoid travel for a few weeks too. So syncope is fainting. So it's usually, is it cardiac syncope? Like you have an arrhythmia or a funny heartbeat that causes you to lose blood supply to your brain, and then you pass out, versus your vagal nerve is strained because of something in your gut or something, and then you pass out. So how do you know? Well, and who wants to take a chance of which one? So that can be, but often, this rapid return of wakefulness is reassuring, and then you just try to observe. But then usually people are on the phone with the ground crew and or the doctors on the ground to try and talk with them. So dizziness and vertigo, very common. Any kind of pressure issues can lead to that. But then there's always the worriness: is it a cardiac event that's happening, or because often cardiac events just start with simple stuff like mild fainting or fainting-like spells, or a bit of nausea, or like you want to throw up, which is vertigo. So you're on healthcare provider. Hey, James, what would be your worst nightmare on a flight? What do you think? Would you not want to?
Anti-vaxxer, anti-masker, going nuts.
Yeah.
Those are always the
No,
worst.
you just get the air marshal to shoot him. What's your second most?
Actually, what's actually I would say that's up there. Sorry for bringing it up, but mental health stuff. Oh, yeah? I've heard some really nasty stories of because they're uncontrollable, right? And you're right. I guess air marshal can help. I guess that you see, they're real. You see these guys who are duct taped to their seat, right? And it's just disruptive, and it causes a lot of it's almost like an act of terrorism.
Okay, after that, what would be your next worst nightmare?
Yeah, honestly, it probably just be a cardiac arrest. Honestly, that'll probably be
Really?
Actually an airway issue, probably the biggest one, right?
Yeah.
For me.
But you know what to do with an airway issue.
Yeah, but if you don't have the tools though, like everyone says, oh, the ER doc is here, everything's safe, but it doesn't help when Hawaiian Airlines is probably the worst kits that there are for medical. And I've actually written them, and I've talked to the medical people, and they still refuse because they're too expensive, right? They don't want to spend the money, right?
But if you had to do an emergency cricothyrotomy, you could.
But do I have the oxygen and the stuff to hook it up to, right? That's the other thing, right? It's sometimes they don't have those.
Let's just assume you do.
Anyway. So what kind of things are you talking about then? Like, are you like delivering a baby?
This. Yeah.
No, that's not that bad, Rob. That's not
really
that bad.
That would be the scare. You're actually
probably for you. Probably for you.
Actually, you're right. It isn't that bad. They don't turn out that bad. But for me, if this is what I was asked to see, I would be freaking out, because not your 2 young lives are now, but honestly, people have been delivering babies for millennia, since day one. So an ob-gyne thing on board is my biggest worry. But a lot of babies are born every year, and we actually have very little role other than provide reassurance, and then probably the guys on the emergency room in Denver will help you to decide what to do next. Miscarriages have occurred occasionally. Examination facilities are limited. General conditioning is only, because these are otherwise healthy young females and people have delivered all over. So they usually don't turn out too bad. So what about flying while pregnant? Most airlines will not allow you to travel after 36 weeks of pregnancy, or week 32 if you're pregnant with multiples or twins. That's according to the National Health Service in the UK. And then sometimes they want fitness to fly. Okay, in the air, your team, medications, equipment, medical, legal stuff, documentation. So the pilot is actually the captain. So even though if James Ham, MD, FACEP is up there, he doesn't have the final decision regarding diversion and altitude changes. In fact, most of the real decisions are made by the medical crew on the ground. And right now, what modern flights do, it's the medical crew on the ground, but where people who with medical training are involved, they're more to do things like physical exam, finding out what's really going on, taking a decent history, helping to administer a medication, maybe start an IV, get the AED on, and that kind of thing. That's where we're more helpful. But the actual big decisions about diversion and stuff like that are really not, like in the one time I was in 1988, wasn't up to me. It wouldn't be up to me to a medical student to divert a plane. No way, that wouldn't happen today. So the cabin crew, they're all usually trained. All cabin crews used to be nurses before World War II, but not anymore. But they're all very well trained. And so they do AED. And the thing I learned from that Samoan scenario I talked to you about at the beginning of the talk, where the poor fellows, the one thing I learned from that is the first thing I'm going to ask for when I'm on a plane is the AED. Get the AED. Where's the AED? Just throw it on, because it tells you what to do. It tells you what to do and takes care of all the things. It gives you your data and it tells you what to do. So that's the first thing I'm going to do. So like in the hospital. So ground support, well, it can take time to connect, but communication is pretty good today. They got emerge docs. They're familiar with in-flight medical situations. They know what most of these planes have in terms of equipment, and they'll know what to consider for diversion. And so remember, all conversations with ground support are recorded too. And so the communication, be respectful, help out. Medical volunteers need to, decide amongst themselves who's the most qualified to run the show. The first medication equipment, I think the medical kits are getting better and better, but they're not all the same everywhere. I think in North America, in Canada, and US, in Europe, it's pretty standardized by now, but some of the medications are a bit different. And some of the equipment varies based on the country. Here's a first aid kit to do all the medications. That's a pretty good list of stuff, IV catheters, pulse oximeters, syringes and needles, naloxone, antipsychotic stuff. So James was looking for the Haldol, and they might have that, and so not a big thing of narcotics, but they'll have steroids that will be helpful for something like, respiratory problems. So things are getting better. AEDs are on, universal precautions. So if you're a provider, I don't want to get involved because I don't want to get sued, but I am not aware of someone on board who used reasonable training to help who's ever been taken to the court. So most places have Good Samaritan Acts. But having said that, jurisdictions differ, and airlines have been sued for people for bad outcomes, but I'm not sure how success of that liability is. So it's important to, so they'll ask to be invited, James, do you have any experience from your emergency room?
Yeah, they always like to shove some airline miles or some free cookies to mail to you or something like that, so then they could actually hold you accountable, which sucks
and that's after you've signed a whole bunch of waivers.
Yeah, but they say it more or less it claims legally. Then they can claim that they gave you something in exchange for your services. So then it removes them. It adds liability to you. Back to you. And there have been cases of that which really suck. So I'll joke, but I'll try to mess up my address one or two if they're trying to send me something, or I don't know, and they'll still somehow get to me. I don't know. So I guess there aren't too many James Ham MDs in Honolulu, I guess, but it'll somehow get to me. But yeah, then what do I do with the box of Big Island cookies, right? It's like at one point I think I had 6 boxes stacked up in my apartment when I was single, and I would just give them out to wait for Christmas to hand them out, I guess.
Give it to me, James.
In the US and Canada, you don't have to except in Quebec, you have to report for an emergency if they're looking for a provider. In the United Kingdom, you're obliged to the call. So it's a little bit different in where it places. So diversion factors to consider. What's the urgency? Is but a lot of airlines don't want to divert because, and the captain has the final answer. So diversional factors to consider, because sometimes you got to dump fuel before you can land, and then some places don't have a landing length like on an island. May not be able to, and then so costs can be high. And then, so is there a doctor on the plane? Airlines often hope there aren't, and because they don't want to have to make these decisions, and they'll use their crews on the ground to help them make their decisions. But what about deaths? So if resuscitation starts, do you stop? If you stop, James, are you going to say, okay, I'm going to call it? Well, first of all, what country are you in when you're at 36,000 feet? If you're in a certain countries, they might, you're responsible. And then when you land, then you're in big trouble. So airline policies differ. So probably the safest thing is keep doing CPR until you land. And then the paramedics on the ground can, so you have to be careful with that. DNR, do not resuscitate. I'm not going to get in. That's pretty complicated. So here's another question. So an airborne baby, what is their nationality? Anybody know? Well, so if the country is a signatory to the Convention of the Reduction of Statelessness, then the child is a national of the nation where the plane is registered. But if they're not a signatory, then the location of the airplane in international airspace is the child's nationality. And then if the country will not allow a citizenship, then it takes the mother or father's citizenship. So it can be a bit confusing, but it's the same on airplanes as it is on cruise ships. So it depends on if the country is a signatory of the convention. So who knows? Where's the safest place on a plane? According to studies, it's probably the back of their survival rates. Or it's, best is in the back of the plane. So first class, you're gone. Back of the plane, maybe you're better. So can an aircraft just disappear? Have aircrafts ever disappeared? Well, between 1948 and 2014, 85 aircraft have vanished without a trace, and 26 of them were passenger jets. I can't believe this statistic. 59 were lost at sea and 26 went missing over land. And just think, how can this happen? But just think of Malaysia Flight 379. They stopped looking after 3 years. After it flew off into the ocean somewhere. And so in 2017, they can't fly a plane. I thought they could find anything, anywhere, somewhere, but they can't. They haven't. And I think they're still, well, I don't know if they're looking for it, but probably somebody is. And so, okay, some more trivia. There's a black triangle in a plane. Does anybody know what that black triangle means? Well, it's for the captain. So the captain, if they want to check the engine flaps or slats, then, and it's dark at night, then he just looks for that black triangle on the inside of the cabin, and then he looks out that window. So that's the best vantage point for the window seat to look out. So that's, and then there are others. So Back to the Future. Well, what's happening after COVID-19? I'm finished my talk now, so I'll leave it open to questions, and I'll stop sharing and I'll entertain questions or comments. Well, I'm not going to get into, I don't think we have time.
I don't have any questions, but I learned a lot from you.
Oh yeah, okay, thanks.
Right. I just want to say, as an additional precaution, if you have cardiac problems or, as I do, clotting problems, perhaps medical identification,
Yeah,
bracelet or
point.
whatever,
Great point.
stating what you have,
Yes.
so they know then how to respond.
So what does your medical alert say?
Well, it did say, that
You don't have one,
blood
do you?
thinner. I had Meniere's before, inner ear balance
Okay.
problem. So
Yeah.
it says I am not drunk. I have, Meniere's disease, et cetera, et cetera.
I see.
So because that was their first thought. This guy is drunk,
Right, right,
so,
right. Yeah.
But
Yeah.
I am gonna get one that says, antiphospholipid syndrome, prone to strokes, taking blood thinners, so that they'll know, if something happens, how to treat me.
The other thing that can happen is that I've seen before is for pre-existing things is denial. So I was a coroner in Ontario, and I remember doing a coroner's case at the Ottawa airport after a flight from the Caribbean, where a guy was sick and he got on board, cardiac symptoms, but he just wanted to get home, didn't want to stay in Jamaica or wherever he was, and so that kind of denial. and then he got on board, and that's just the wrong decision to make. If you're having symptoms, trying to get home is by flying, I'm going to get home to a real hospital. I don't know about that. So people with pre-existing conditions have to do exactly what John's saying. Have some kind of identity. When John can't talk, something that can tell someone that he's not drunk, that he has these conditions. So a medical alert can be very good. And then just be smart about not getting on board if you're already feeling ill. So, yes, sir, Rod.
It's a question for Naomi. Paul, first of all, I really appreciate your presentation.
Thank you.
I think you'd be really useful for general public to hear what you're saying, because most people don't even know this stuff.
Mhm.
And Naomi, will this be available? Can we share this with others?
Yes, I'll convert this to YouTube and you can share it with others.
Excellent, excellent. Thank you very much, Paul. That was really
I think
great.
it'll be
you're
perfect
welcome.
for us no, I just wanted to add that it'll be perfect for us for pre-trip, future pre-trip district travel, right? Just to have, if we're planning a trip as a group or just in general, I think it's perfect. And if a club, needs a lecture for one of their meetings or something, or not a presentation for one of their meetings, pop it up and have it play, right? It's perfect.
Absolutely.
Thanks, Paul. This is actually a really well put together presentation.
Thank
Yeah,
you.
excellent. Thank you, Paul. That was great.
Yep.
Yeah, I have one more thing. It's really good to know that I don't really have to worry about getting COVID on an airplane. I mean, it's pretty safe. Yeah.
Well, actually, airports are a hotspot right now. And the reason for that is that, and it's not medical, it's political, I think. It's some of these jurisdictions letting people non-vaxxed, symptomatic people getting on to a flight, or, not wearing masks in certain areas, like in Florida and things like that. And so people are dropping their guard in high density areas, and and a lot of that happens to be in airports. So I thought airports used to be quite safe. I think, 1.5 years into the pandemic, everybody was so careful. And I think it worked because the PPE worked and the distancing worked. But now people are flocking to travel. They're flaunting. They're not using really good masks. They're using crap masks. They're not Purelling like they should. What do you think, James?
No, I think the biggest choke points are actually in the jetway. When people are getting onto the plane, you're literally in this little tube of concrete or metal, whatever the heck it is, and air exchanges are happening there. Honestly, this is kind of crazy, but rather than wearing masks, honestly, I think mandatory hand sanitizer probably the best thing to do. Probably something like that, right? Because you're spraying by touching your mouth, right? You're also doing those kinds of things. So that's kind of the thing to worry about. I know it is respiratory, but those droplets get on your hand, and you touch other things, and those droplets then touch others. So I think ultimately, obviously the air exchanges are important, and I think that's what they say. The planes are the safest. The airports are the most unsafe. So it's kind of, you're in this. So I guess it's a wash, right? I guess it averages out to be the same depending on the risk, right?
Planes are very cavalier now about handing out the sanitizing little wraps. And I always do it. I was just on Maui the other week doing a clinic, and I'm looking around and no one else is doing that. Everyone's forgotten about that. And and I always carry a Purell thing. This is my little tube of Purell. I've always carry it full, and I just do it constantly, especially in airports, because everything you touch to me is infected till proven otherwise. So, yeah. Super duper.
This is great. I know you guys saw the prelude to Paul's kind of presentation, but we'll give that presentation on Saturday if that's all right, Paul.
Yeah.
And then we can record it then too. So if you guys
Okay.
can't make it on Saturday, but obviously we'd love to all have you guys at the district training seminars going on this Friday. Is it 9 or 9:30? I'm sorry, I don't have it on me right now, but I believe it's. Let me look at my calendar. I believe it's
9:30 on Saturday.
9:30. Okay, thank you. Oh, is it 9 or 9:30?
Oh, it starts at 9, but the
Okay.
breakout session is 9:30.
Gotcha. And then so we'll have a separate health a breakout session, and we actually have I believe 3 or 4 others that are going to be kind of doing a panel. So we're just doing a panel talk, honestly, about different local health related projects or different ways that clubs, because it's going to be mostly board members or new Rotarians or people that are interested in leadership. And I know all of you are, so it's a perfect place for you guys to be there. But I would say that at the end, we'd like to definitely give Paul a spotlight to actually showcase his presentation, because he's definitely done a lot of work to support the medical efforts, specifically in Ukraine refugees and Ukraine victims of the war. So
How much time will I have for that, James?
well, how much time do you need? Because
20 minutes.
Okay, yeah, I could talk it over with I think we have a total of 45 minutes. So I think that's enough time, because honestly, a Q&A
I could talk for 30 minutes.
Yeah, but yeah, exactly. So we could give the panel about 15-20 minutes and then give you the rest at a 45.
Okay, I don't want to hog it all, but
Well, it depends. Like I said, we could depend, and then obviously we could play it by ear. And I just know it's a breakout session, so it won't be this. We won't have the capability of kind of extending at the end of the breakout, or like shut off automatically and kick us back to the main group. So, but what we could do is at that time, we'll, like I said, I think all of the people that are participating are very, very cool, and no one has like an actual formal presentation. So I think everyone's just understanding that's a panel. So we're going to just talk about, like I said, I think I have some questions written down. One is, what are some things that your club has done, for the health of your members or whatever. I'm not going to put people on the spot. Just, someone could talk about it. And the other one will be like, what are some projects in the community that are health related, pre and post COVID, what are some things that you guys are doing? And do you guys have anything in store in mind that maybe other clubs could collaborate with you on for the future? And then we have this project, which falls perfectly in line with that, right? Because it's definitely a multi-club, district level, if you want to call it that, even type of project. And it's international. It hits a lot of different buttons for people. And I really like. I hate saying this, but it's a long haul, right? I mean, there's not going to be resolution of the situation, unfortunately, anytime too soon. So I think just letting people know, hey, ideas for next year, even, just keep these kinds of projects in mind. But and I'm assuming these efforts that you're supporting, they're going to be ongoing, right? It's not a one and done kind of scenario. So I think just letting people know, and I think it'd be really helpful also, when you're there in harm's way, and not necessarily harm's way. I hope you're not in harm's way, put that way, Paul. But if you're there in Poland, dealing in the muck, the mental harm, right, that's happening to you, because you're going to be suffering, unfortunately, from seeing all these atrocities happening. But I think when you're there, if you could spend some time with us, it'd be awesome to do a little talk with you there. And help you decompress too a little bit, right? Because talking about helps, right? So we definitely like to talk. Set up a time when next month, if you're there to make this happen. But
Awesome.
yeah, I mean, we'll wrap up. I think, hey, Paul, are you gonna make it to the club meeting tonight?
Yep. Yep.
Cool. So yeah, it gives us time. But for the rest of you guys, if you guys do you have any other questions? Sorry for kind of barging in and kind of taking the spotlight here, but any other questions? Alan, John, Rod?
If any clubs out there want a speaker in the next few weeks, and I'm happy to talk about the Ukraine thing, because the Russians are going to probably start to really turn up the heat in the eastern part, and they're just going to bomb the crap out of Donbass and Luhansk and Kharkiv, because they've lost the other, attempts to get Kyiv and other places. And so I think Putin is going to just try and take that land bridge towards Crimea, and then. So it's going to be really bad for those places. And so, I'm trying to get my medical gear to Kharkiv where I know a couple of surgeons there, and that's right in that area. So, I'm trying to get some funds and to send things over, tourniquets and orthopedic equipment in particular. And so there's a bit of time factor to it as well. But James, you're absolutely right. This is going to be a long haul, I think. I wish it would end quickly,
Unfortunately,
but
yeah.
I can't. Yeah. So anyway, yeah, thanks for, yeah.
Is there a Rotary Club on Poland side that they can apply for one of the disaster funds?
They're the Rotary International Rotary Fellowship for Health Providers is a great club. And it's not a club, it's a subgroup, I guess. And a guy named John Phillips and I think James, you're a member, and I'm a member, Claire's a member. And so basically they are totally working with Romanian Rotary clubs, Slovenia, Lviv in Ukraine, Poland. It's become a very impressive network of connections of getting stuff in, because they're just like us. They're the local movers and shakers. And so what would be a better group of people to get involved in for getting stuff in? So yeah, that's already happening in a big way.
But if they're going to do a global grant, then we can contribute to that global grant.
Sure. Oh yeah. Or you can contribute to the International Rotary. I can never forget the acronym. They got to have an easier acronym.
Yeah, the Rotary International Fellowship for Healthcare Professionals.
Yeah.
But Naomi, I'll reach out to John Phillips, who's the head of that, and he actually has some specific contacts, and I could ask them if they have any specific global grants and any of that in mind too, because they actually are working with a few specific clubs. I believe there's one in Warsaw that they're working with specifically, but I could ask and then find out, and we contribute.
Yep.
Okay, so to get money to help Paul with his efforts, we just need to know where to put the money.
Okay, so Mark Merriam, can we hit a share screen? Can you hit my share screen? Or am I, okay, here, I'm gonna show you. So here's my, so this is how these are ways that you can, there's 3 ways that you can donate for the Hope for Ukraine Fund, which is the Hawaiian Orthopedic Project for External Fixators. And I was gonna talk about what are external fixators, why do they need them, what else do they need, blah, blah, blah. And so donations are being made through Mark Merriam, the Rotary D5000 Foundation treasurer. You can either mail a check to him, you can hit this blue thing to pay with PayPal, credit card, or debit, or you can anybody try, James, can you take your phone, and does that Qbot work on your phone off a?
The QR code, it works.
No way, see? So you could just look at this, and that is so cool.
Yeah, it is, but I would prefer to give it to a global grant rather than to the district foundation.
Yeah.
So unless you're saying that the district foundation is going to give it to that global grant or to the fellowship.
No, this fund is for me to provide external fixators to the group in Kharkiv. But I mean, there's lots of groups you can donate funds to.
Yeah, but we want to get it to you. So, if
This will be the best way to get it to Paul, honestly, Naomi, because this is going to go directly just to him. I mean, ultimately, it's going to be. I think our club is going to be the one who's going to be sorting out all the stuff for it.
James, we can talk about this at the meeting, but should we?
Yeah.
Yeah, and I think I texted you asking you, is there a way to convert this into a quickie global grant of any kind, or?
Unfortunately, it's not, because it's going to take it's going to take 6 months, I would say, for the life cycle, and not only that, it'll take longer because we'll have to start the process in July, right? So
yeah,
it'll take a while, unfortunately, but
Okay. Well, no, for the disaster funds, those are priority. They're expediting those grants, but then you need that
we need a local club, though. That's the problem. That's the problem right now for us right now. And I don't know if that local club is going to be, because the issue is going to be you having a relationship with that local club. So I guess what I challenge you in May, if this is going to be potentially a long haul kind of situation.
Yeah.
If you could, when you're on the ground, or maybe even now, you could just ask ask your contacts in Poland or
Yeah.
ask your contacts at
Yeah.
Kharkiv.
Yeah.
Do you guys have any Rotary contacts? And is there a club? Are there people that I can
Yeah.
talk with? And then maybe go to a meeting while you're there if you can,
Yeah.
or just meet some people there when you're
Yeah.
there. And then we could then draft this, and I'll be happy to work on it. Naomi and I
Yep.
can probably
I got
work
it,
on
yeah.
this probably in a couple of days, right? Just draft
So
something up.
this particular funding, this is not going to be a long-term funding thing. This is going to be a relatively short program here. I just want to get enough funds to get the gear I have here, and then a bunch of tourniquets and maybe some more external fixators to these guys in Kharkiv who will share it between the civilian and the military hospital, and then I'll call it a day. So this won't be an ongoing thing. So I don't think it's appropriate for a Global grant, but I'm sure there are lots of other opportunities for participating in global grants. And just like James says, I'll be in a position to find those clubs in Lviv and elsewhere that can participate. So gotcha.
And then we could circle with the Rotary International Fellowship for Healthcare Providers too. I think it's RIFHP.
Something like that,
I
yeah.
was calling that RIFHPs, whatever.
It
those
doesn't
guys.
roll off the tongue
It
though,
doesn't.
so it's hard.
Yeah. It's initially I was calling it RFIDs, right? Because but
Yeah,
that's not it. That's the chips, right?
Yeah.
Okay, I'm gonna stop recording here.
Okay.